and parent groups that meet on Monday and Thursday night, I think, which are free. Again, to give support, to get objectivity, get some input from other parents or family members who've gone through the same thing. And just getting that extra input, getting the support, but more importantly, getting perspective, a different perspective on the situation can be powerful and can really help significant others.
From the standpoint of your research, you are published on several publications out there. Has there been something that you found in the course of that research and publication that surprised you in the whole opioid addiction issue?
Not really. I mean, I think the important thing with opiates is that is to think about it long term. I think opiates are similar to other addictions in that regard, is that certainly it would be wrong to have an expectation, or it would be unrealistic to have an expectation that a single treatment without any other continuing support and continuing care would be effective. That's probably one of the things, I suppose, in that regard, Larry, in terms of is the long-term aspect of recovery. That people need support for a long time. We're talking 5 to 10 years of continuing some kind of supportive aspect, whether that's through professional or mutual help or community resources or a mixture of the two over time to help people really stay the course, because addiction really hijacks the brain and changes the brain quite substantially. Mm-hmm. And depending on the substance you're using, it can also have neurotoxic effects. That means that it kills millions and millions and millions of brain cells as well. And the brain can recover some of that lost capacity, but it takes time for it to do that. And as you can imagine, when people early on are trying to make these changes, it can be very challenging for them, and that's why they need the guide wheels. They need to be able to get the guidance and support that can help them sustain it over the long term. So that is perhaps in all of my kind of reading of the research base and doing research myself over the long term, you see that this is a long-term problem that is susceptible to relapse, but still most people who have addiction recover. That's the good news.
In relationship to that long-term support base, there are programs out there similar to sober houses, for instance. You know, what has been your experience or research in relationship to sober houses, a good outlet for the addict versus going back home or maybe moving back into the neighborhood where the addiction problem started up? Is that, are they workable? And you know, tell me what
there's good research on. It's a great question. There's good research now on extended sober living. So living in a sober community, in a sober house or other long-term residential therapeutic communities, shown to be very effective. They can produce very good long-term outcomes because you're living in a structured environment that's protective, right? It's restricted in the sense that, I mean, people can come and go and they're encouraged to get jobs, but they're monitored. The monitoring of their substance use is done typically through a biological assay, like a urine toxicology screen, something like that. So they monitor the drug use, help provide that guidance and support, structure, expectation. That's very important for people. And also the social milieu, that they have that support from other people who are going through the same problem, peers, that peer support.
The peer support versus the peer pressure.
Right, exactly.
That may have gotten that may have gotten them into the problem to begin with, right?
Yeah, exactly, you know? And they can provide long-term support. And the evidence, the research on that does show very strong effects, long-term effects for people who remain in those sober environments, sober houses.
In some of your research, you mentioned about improving treatment quality. What does that mean, you know, from the standpoint of, is the treatment today not up to where it needs to be, or are you looking for better ways to improve that treatment?
I think always we can improve the quality of the services that we deliver. When national surveys are done, and this is really not the fault, I don't think, of the treatment system overall, because unfortunately, the treatment system does not get a lot of financial support and resource to be able to produce a high quality service, unfortunately, for the care of substance use disorder. However, there are programs out there that mostly privately funded programs that are able to utilize extra resources, get extra income to be able to produce higher quality treatments. But the average treatment is not able to do that typically. And what I mean by quality treatment is things like using standardized assessment tools, which are validated assessments, so you really get a good picture of the person and the nature and depth of their problems that are affecting their lives, psychiatric, psychological problems, social problems, nature, intensity of their addiction, their longevity of their substance use, and so on. All of those things are very important, and there are standardized measures which can capture that well and efficiently. Many programs don't use standardized assessment tools, so it's hard to know exactly what people are getting. Other aspects in terms of using treatments which we know have some kind of evidence base for their effectiveness. That's another aspect. Having licensed staff that are licensed alcohol and drug counselors, for example, or licensed social workers that can deliver treatment with competence and who have the professional training to be able to do that well. People with empathy that can empathize and understand where the individual is coming from, to be able to help them and truly listen to them. Having empathy is another quality indicator. Having continuing care, making sure that people are understanding that we're treating and acting like we're treating a chronic illness. So making sure that we have these assertive linkages in place to help people get to the next level of care to support long-term recovery. Some of those are some of the quality indicators which we actually have in our program by design, but is difficult for a lot of programs. There's about 8 or 9 of these quality indicators.
What type of stigma do you find is associated with the addiction issue that you hear from, your patients that you're treating?
Well, we find mostly we hear on the other end, on the not so much on the treatment access end. I think patients themselves feel inhibited to come in to treatment because they are oftentimes ashamed of being addicted, or the family members are ashamed of having a family member who is addicted. Interestingly, the World Health Organization did a study of 18 of the most stigmatized conditions in 14 countries around the world. And they had things like being a criminal, being HIV positive, having AIDS, having addiction to alcohol or another drug, and had 14 of the most stigmatized conditions. Number 1 came out was drug addiction. Number 4 was alcohol addiction.
Really?
Out of those conditions across these 14 countries. So what we're talking about is a universally stigmatized condition, possibly the most stigmatized social problem that we have. So when you consider that we are dealing with a problem whereby only 10% of people get treatment each year, out of the 100% who have it.
Right.
And like I said, we see people on the other end when they're trying to find a job, when they have a criminal record in their past that won't go away, and that the authorities don't want them to shed. They want to have them keep it. Makes it very difficult for people to outgrow the stigma and history of their own addiction and move on with their life.
Well, I think that's probably one of the most important issues that the young generation today who are experimenting or being exposed to these particular drugs out there, is that they don't realize the long-term consequences. Whether it's not only their health, but their ability to make a living and so forth out there. I'm seeing that we're out of time, so I want to take this moment and thank you, Dr. Kelly, for joining us again and sharing with us, some of your experiences, your research, and findings as part of your program over at Mass General Hospital. And thank you for being a guest on our show.
My pleasure.
You again.
Thanks, Larry.
Thank you.